up okay? All right. So I am honored and humbled to be part of this lineup of speakers. And I'll say when Nelson sent the invitation, he used the word inspire. I said, Nelson, what do you want me to talk about? He said, we want inspiration. I said, okay, well. I thought, here's my inspiration. And I think it's probably the inspiration for any of the clinicians in the room, to be sure. It's the patient at the bedside. And it's what we see every day in our clinical lives. And so I thought, well, if I'm going to be inspirational, I'm going to be aspirational. And I'm going to think, okay, what is it that we really want? What's that pie in the sky ideal goal? And this is what I want. I want to know that every decision that I make for each individual patient will maximize their chances of living a long and healthy life. Because these are children, right? We want to maximize not just their short-term outcomes, but also those long-term outcomes as well. Well, that's kind of a tall order, but it is the goal. This is where we want to go. And so when I think about how do we operationalize that goal, I come back to some of the things that have already been talked about this morning, and that's how do we make decisions at the bedside, right? So I'm back here at the bedside, how do we make those decisions now? And certainly we have some evidence base that we fall back on. We think about our understanding of pathophysiology, but we're also thinking about that patient in front of us, as well as where that patient has been. We're thinking about the trajectory. Where was that patient 5 minutes ago, an hour ago? We're integrating multiple streams of data at the bedside. We're looking at the ventilator, we're looking at the monitor, we're looking in the EHR, we're looking at the labs, the imaging. I would posit that there's a lot of data there that we don't see as humans, but even what we do see, we're integrating in ways that our clinical trials have yet to recapitulate. And so taking one relatively simple decision, Alan Doctor and colleagues at WashU some years ago put together essentially a mental map of how do intensivists, or at least how do they think or say that they decide when to give a red cell transfusion. Now, the point of this figure isn't to follow all the arrows and read all the words, it's to understand that this is complex. And this is one of dozens of decisions that we make every day for our patients. And so we have complexity upon complexity. And so we go to where our evidence base is, because for red cell transfusion in the PICU, this is someplace where we actually do have RCT data. And our RCT that exists says, well, there was no significant difference in outcomes, that being the development of NP-MODs, if you transfuse to a goal hemoglobin of 9.5 versus 7. Well, here we have to think about the standard assumption of a clinical trial, right? So that assumption is that I have a sample population. There's a couple of assumptions right there when I say sample population. The assumption is that my population is going to be generalizable to the patients that I'm going to apply the results of the trial to. It's also that you're going to have the same effect of that treatment across the population. And so I can apply my therapy, I can measure my effect. As clinicians at the bedside, we kind of know that assumption is probably false, right? So we know that within our cohorts, as they are currently defined, sepsis, ARDS, multiple organ dysfunction, there's a huge degree of heterogeneity in the underlying biology of our patients, and we would predict that many of our therapies probably would have heterogeneity of treatment effects. And so if you think just conceptually about, I have a trial, I'm going to apply a therapy versus placebo, and I'm going to measure the effect at the end of the day. What happens if there are some patients within my population for whom it doesn't really matter what you do with respect to that therapy, they're going to have whatever outcome they're going to have. But what happens if there are some patients where that therapy is beneficial and some patients where that therapy is harmful? At the end of the day, you may get an effect at the population level that is not helpful for making individual patient decisions. So the adult ARDS world has been onto this for a little while and has really, I think, been at the forefront of thinking about heterogeneity of treatment effect in critical care clinical trials. And as was reviewed recently, depending on how you define phenotype, and of course I'm using the word phenotype loosely here because there are a myriad of ways that one could define phenotype, endotype, we even have different names for it. But whether you define that based on severity of illness, whether you define that based on response to therapy, whether certainly in pediatrics we have the added heterogeneity of developmental changes over the pediatric age range. But some of the more interesting studies here are the post hoc analyses that have gone back and looked at biomarkers of differences in immune and inflammatory response in patients with ARDS and have found evidence of heterogeneity of treatment effect. And as Martha mentioned this study briefly, but turns out that pediatric patients with ARDS probably have different phenotypes as well, based on some of the similar biomarkers that have been looked at in adults. And what I find interesting about this figure, so here basically it's a graphical depiction of these two different phenotypes that were identified by latent class analysis. And what's interesting is some of the clinical characteristics that you might ordinarily think about dividing patients into subgroups. So, age is right here toward the middle. Oxygenation index is sort of toward the middle, where there's not as much separation between phenotypes as there are for some of those biomarkers that we don't currently clinically measure. And so it's worth thinking about, is there differential treatment effect for our ARDS therapies among these two phenotypes? There probably is, and certainly the Prospect trial is an example of embedding biomarkers to be able to go back and answer this question. This isn't just ARDS, sepsis, this probably happens as well. So Hector Wong's group in Cincinnati for years has been thinking about subphenotypes of pediatric sepsis. And if you look at these subclasses defined by transcriptomics of 100 genes that are largely in the immune pathways, and you look at, in at least observational studies, associations between corticosteroid use and outcomes, it looks like they may differ based on which endotype patient is in. And of course, this question is also being prospectively evaluated as part of the SHIPS trial. And certainly, there's also been a long-standing interest within the CAPCORN network, and Joe Carcillo and others, about trying to understand subphenotypes within sepsis that would be expected to have a different response to different targeted therapies. So, specific to immunoparalysis or macrophage activation-like syndrome, this hyperinflammatory sepsis syndromes, as Mike, I think, briefly mentioned, this is the target of the current PRECISE trial that is enrolling now. And I thought I couldn't really come up here and talk about precision medicine without talking about PRECISE. But this is an RCT where children are enrolled into the trial, a blood sample is taken, based on the results of an LPS-induced TNF-alpha production capacity test to identify immunoparalysis, combined with the biomarkers of ferritin and CRP to identify macrophage activation-like sepsis or hyperinflammatory sepsis. Kids are either randomized to GM-CSF versus placebo for immunoparalysis or anakinra versus placebo for hyperinflammation. And so it's a next step in that pathway to how do we design clinical trials to advance precision medicine, to get away from treating all sepsis the same, all ARDS the same, et cetera. So coming back to the transfusion example, right? It's one thing to say that, of course, if you have targeted therapies, they probably should be applied based on phenotypes, but what about supportive care? Something that, would it really matter what your patient's phenotype is or what your patient's underlying biology is, it's anemia, just fix the anemia. Well, what's interesting is when we look at kids with severe sepsis or septic shock, and we look for the interaction of the relationship between red cell transfusion and outcomes based on severity of shock, we see differences, right? So if you take all comers and you say, is red cell transfusion associated with poor outcomes in critical illness? The answer is yes. Of course, that's multifactorial, right? Because sicker kids get transfused, and you really can't separate that out in an observational study. But it's more interesting because even in observational studies, if you look at something like shock, which makes some sense, you can identify kids for whom, if there is little to no shock, red cell transfusion is in fact associated with adverse outcomes. But for kids who are in shock, a red cell transfusion, regardless of hemoglobin at which they are transfused, may actually be beneficial. And if we look at the same figure with hemoglobin, the lines are exactly parallel. So clearly hemoglobin probably isn't the right way to do this, right? But we still don't know what is. And, oh, by the way, if we look at inflammatory biomarkers, we also see interaction effects that are very interesting that again suggest that patients who are at lower risk who are transfused, there is more of a relationship between, adverse relationship between transfusion and outcomes compared to those kids who are at higher risk or more inflamed. So, given what we know so far, I think at this point, we need to move away from, is it possible? And here I agree with Mike. It's imperative that precision medicine in the PICU is necessary, and certainly it's where we're going. And I'm going to throw another layer of complexity in, and that is that trajectory matters too. And so, that's going to make it, I'm among friends, so I can make this joke. I think as long as I work at Nationwide Children's Hospital, I may be contractually obligated to have this figure in every presentation I give. But the reason the figure is here is to talk about the fact that the underlying trajectory of the pathophysiology that we are trying to address in our patients changes over time. Organ dysfunction, both single and multiple, evolves over time. And of course, we see this at the bedside. We not only see it, but we cause it. Because if I'm at the bedside of a sick child, and if they're not getting better, if they're not changing, I'm doing stuff to make them change, to make them get better. And so when we think about how do we evaluate precision medicine in the ICU, we need to think about not only the heterogeneity between patients, but the heterogeneity of the same patient over time. And how do we incorporate changes over time, response to therapies that have already been given, response to therapies that are being given at the exact same time as whatever it is that we're trying to evaluate, because for sure there are probably meaningful interaction effects among the myriad of different things that we're doing at the same time. And could we even predict how therapies that we're about to give could interact with the therapy that we're evaluating? Like this, I think, is a unique challenge to the critical care environment. And I think that's the unique challenge to those of us in this room because, different from other subspecialties, our patients and their clinical condition don't evolve over weeks to months or even years. They evolve over minutes to maybe hours, right? Traditional manual data collection can't give you the data that you need to tease that out. And it's a real challenge in our current study designs, and I think it's a challenge that this group is well poised to address. So in terms of thinking about, and at the expense of providing high level overview of a machine learning project, not being a data scientist in the room, I'm gonna go for it anyway. I collaboratively work with really smart statisticians and data scientists, but this idea of incorporating trajectory and trying to build decision support tools that will change over time as the patient changes really is at the core of our current ongoing observational study, where we intend to use outcome-weighted learning and other deep learning techniques to try to understand which treatment decision to transfuse or not transfuse will optimize patient outcomes based on those static variables as well as variables that are changing over time and trajectory of the patient. And just as a sort of example of what an output like this might look like, this is a limited data set with just static variables here, but you can see how the output of the model can be converted into a decision. Do you transfuse, do you not transfuse, and can include a linear output that can sort of tell you, well, how far on the transfuse or not transfuse are your patient's points. So I'm going to leave you with one last motivational challenge. We heard just moments ago about outcomes. And here's something that actually occurred to me as I was putting these slides together. We think a lot as clinicians and researchers about the heterogeneity of the biology, but what about heterogeneity of outcomes? Like, what do we do? How do we design our studies? How do we make clinical decisions when the outcome that is most important to the patient and family in room 12 is different from the outcome that is most important to the patient and family in room 15? I don't have an answer for this one. But I thought it would be a good motivational question to pose to the group, because I think it's right to be thoughtful about family-centered outcomes, but I don't think we can consider family as one monolith. There's heterogeneity in there, and different families will likely have different priorities for outcomes for their children. And so a little bit about, from my point of view, of I think what we need to get there. I think we need to be able to phenotype patients in real time in ways that are feasible, that are deployable across multiple centers. We need to be able to incorporate those phenotypes into models that can predict response to treatment decisions. So I guess I'm back in 1985, Mike, and still aspirationally trying to get there. We need to make sure that we understand how our treatments are interacting with each other and interacting with the trajectory of the patient. And this last point here I think is really important for this group moving forward and for others in the field, is making sure that the data sets that we are using are not introducing bias and inadvertently causing harm. There's a lot of examples of unintended harm from biased data sets. We, looking at Adam in the back, need computer-human interfaces that can implement these models, that can be evaluated, that make them easy for the clinician to use, easy for adoption, but not so transparent that the clinician doesn't know where they're coming from and can't also use the clinical brain, right? And then data. Obviously, we need data to drive all of this, and innovative trial designs, just as Martha just presented, because if we're taking rare populations and now we're further subdividing them into subgroups, that really requires a rethinking of how we evaluate safety and efficacy, not only with innovative trial designs, but things like learning healthcare systems, implementation, effectiveness trials. How do we learn from every patient so that we can iteratively continue to get better? And that's all I have. I'll say thank you.